good morning everyone. I think the mic is a formality, but let's start with it. And thank you for being here. And we learn this time after time that when you have an early morning course, although you don't have people outside of your group who might be listening to you, but I think for me, we learn a lot because we discuss amongst ourselves and we get time to really understand what we are doing. So we have, I thank Dr. Rohan and Dr. Tushya for being here early this morning, and Dr. Gaurav Luthra will be joining us. Dr. Vandana Nath, our own team member from REH, so no special thanks, but thank you for always being there. Let's start with this topic of nucleus rotation, tackling the snag in successful phaco. I'm talking on behalf, originally this was to be presented by Dr. Prakash Chaudhary from Bangladesh, but because of visa issues, unfortunately, he couldn't make it. So, yes, we do receive occasional research grant from Alcon Laboratories. Let's start with this case of a 66-year-old lady who was scheduled for a routine cataract surgery. And as you can see here, this clip I've put just to show that this is the end of fragment removal and everything looks absolutely fine. Now just notice here when the IA is started, this is when the surgeon, while performing aspiration, noticed a zonular dialysis. And very smartly, the good thing the surgeon did was to start off by refluxing. Reflux on your pedal, that is something you need to know if you catch a posterior capsule or some vitreous or whatever you didn't want to catch. Now going back, the point is, why did this happen? Everything looked quite okay. So the one point that I have learned is to record all your videos, because if you want to review or if you want to go back to them, you should have something to go back to. So this is a phase where a sculpting was done. Hydro had been done prior to this, but the nucleus rotation is being performed. And here you can see what is happening. So it was an, what do you say, a wrong or a bad technique of nucleus rotation, a forceful rotation, push and too much of pull towards the center, although the nucleus was not free. So this was the reason why this happened. So the thing that we learned from this case was that always when you are rotating with a spatula, it is important to understand the physics of nucleus rotation. First prerequisite is to have a good hydrodissection. If you cannot do hydrodissection, let's say in a posterior polar cataract or a pre-existing rupture of any kind, please do not obviously perform hydrodissection. But after a cortical cleaving hydrodissection, it is important to go down and then perform movements with your wrist rather than pushing down. The thing that was happening in the previous case was pushing down too much, which was causing a stress on the zonular complex and caused that dialysis eventually. So as you can see in this animation, this hand figure here, try to make it a swiping motion. Now not every time it will happen that this rotation works perfectly or completely in the first time. This case I have put up to show that a sculpt is being made, and this is what we call an ideal rotation. So where you don't press, you just be on the surface and you do a swiping rotation movement with your wrists. Now here a chop has been created. You can see here that the surgeon is struggling to rotate. So at this point, the smarter thing would be to stop and perform a multi-quadrant, small aliquots of hydrodissection in more than one quadrant. And we like to use this special angled cannula. It's not very fancy, made by one of our own Indian companies. So do it in 2 or 3 quadrants, and then as you can see here, the nucleus will rotate freely. But I think rotation is such an underrated step, because until the nucleus rotates, it is imperative that you don't start any further maneuvers. You may need to stop at any stage where you feel the nucleus is not moving and rehydro until that rotation is free. Good morning, ma'am. Thank you for being here with us. Thank you. So again, like I said, if it does not rotate, then please rehydro at any point. So going back to the original case that I showed you, if you remember, there was an sub-incisional about 2 to 3 clock hours of zonular dialysis. So here the point is putting a CTR, not a very technical thing. You can do it manually or through an injector. But what I wanted to highlight is that here we are using a 10-0 nylon suture, which we have threaded into one eyelet. Why? Because not every time it goes into the desired plane. Sometimes you end up in the sulcus, or sometimes you realize that there was a rupture in the fornix also, posterior capsule rupture, and then it's very difficult to retrieve the CTR. So we like to keep the CTR with the suture in place, and we then cut off the suture once everything is done and then just pull it out. So this is, I think, that case to show the importance of the physics of rotation and what to do if it doesn't rotate. Now this case here, you see that hydrodissection, a good wave has passed. Now once you see that a good wave has passed, what now I like to do, and I think most surgeons at our both centers like to do, we don't check by doing a rotation. We straight ahead go and create a nuclear division, and then we use the chopper in the fornix or the wall of that chop that we have created to rotate the nucleus. So I think if you have a good rotation, you really don't need to, if you have a good hydro, you really don't need to confirm. So you can always crack, and I like to do that also, because once you create a crack or a chop, there is a space through which the fluid from the phaco tip will also flow, and that also aids or augments the hydrodissection. Now again, it's very important when you are using even a chopper for rotation, it's not a great idea to embed the chopper on the surface and rotate. Rather keep it vertical and in parallel to that to the vertical wall of the crack, and then again same wrist rotation like a fulcrum. And the last part of this talk, I want to talk about corticocapsular adhesions. The most common reason for that snag that happened, why it did not rotate despite doing a good hydrodissection, is the presence of these whitish materials called corticocapsular adhesions. Now biochemically they are basically strong adhesions between the capsule and the underlying cortex. And how do you recognize this from a cortical cataract or distinguish it, is the fact that you will not see any space on slit lamp evaluation between the anterior capsule and this opacity. So this is what we call a CCA or a corticocapsular adhesion, whereas here if you see, this is a diagrammatic representation, and this is what clinically it would look on the slit lamp. You will see some space between that cortical opacity, so this is not a true capsular adhesion. So this is important to see in pre-op with a full dilated pupil, so that particularly when you are in a training center or you have multiple surgeons, the person doing the pre-op should mention that this patient has CCA, so that you do a multi-quadrant hydrodissection preemptively. Because as we can easily understand, these adhesions will actually block or stop the passage of a successful wave. And this is, it's a very old picture, but it's a classic one which actually shows what these adhesions look like. And like we discussed in the previous clinical examples, doing a multi-quadrant cortical cleaving hydrodissection not only helps you, but it reduces the time used and the fluid used during the surgery, because it frees up those fragments. And this was documented with the team of Dr. David Apple lab several years ago. So I think in end, rotation, like with any other step, incision, rexes, each step is very crucial, and look for corticocapsular adhesions. Avoid any stressful rotation. Start a crack and try to rotate. If that doesn't work, rehydro, and you can rehydro 1 to 3 times without creating too much pressure, small aliquots. So that's it, I think, on my part from the rotation snag. Now it's my real pleasure to invite next up Dr. Rohan Mehra, and he's like another star sitting. These are all the rising stars of our Indian ophthalmology, and thank you, Rohan, for being here this early morning. He'll be talking to us about a runaway rexis.
And that was a great presentation. Just wanted to ask you, ma'am, at times you have an underlying zonulopathy. So in those cases also you have a difficulty in rotation. So any tips on that?
So I think that's a great question, that when you know or you have found out a zonular problem, one is to use angled cannula and do 2 or 3 small boluses, small aliquots of hydrodissection in that area. And what I also like to do is to do a viscodissection. So we use a dispersive viscoelastic, chondroitin sulfate, and once you do a hydrodissection, you have some space, and I would go through a side port or the main port depending on where that zonular loss is, and I like to perform a viscodissection because one, it frees up, second, when you are performing your maneuvers, it gives you a little cushion. So I think that's also one good idea. Thank you. Any other tips from the experts, Chitra ma'am sitting here, what you would do differently?
Ma'am, what I at ti-
Yes.
Yeah.
what I
Absolutely.
like, I also do one thing differently. Like in cases of generalized zonulopathy, I do a bimanual rotation. So at the same time, you place your phaco tip and the chopper, as you said, it should be placed right in the center, using the angle of the tip, and then you just rotate it. So it simultaneously. So that also like
Yeah,
at
I think
times,
that's also a very good tip because it reduces any focal zonular
yeah.
stress. So great point, Tush. Thank you.
The first case that you showed, ma'am, I will. Went back and you saw that but the rotation was incorrect. But do you think that incorrect hydrodissection also, like hydrodissection not going through on that part, rest of the maybe out of the 360, maybe 330 degrees got hydrodissected, but that part of it did not get hydrodissected, and then there was a forceful movement, and that caused the bag to come
True,
in.
true. So I, like you very rightly pointed out, most of the times there are two issues. One, like we discussed, the corticocapsular adhesions, which will prevent a successful hydrodissection 360 degree, like you said. The other thing, sometimes you, and unintentionally you end up with hydrodelineation, where it's not really between the cortex and the capsule, a little sliver, it goes subcortical, I would say. So that hydrodelineation also is a factor which doesn't sometimes allow. So both a prerequisite of a bad rotation is either adhesions or inadequate hydrodissection, I think.
So, ma'am, are you doing regularly multiple quadrant hydrodissection in overly soft cataracts? Because you know you have strong corticocapsular adhesions in that.
So I do at least two quadrants before I start, and then if it doesn't rotate after my first nucleotomy or division,
Okay.
then I would go ahead and do two more quadrants sub-incisionally.